Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. If you are hearing this right now, then you are not currently a Journal Feed subscriber, and so you'll not be receiving the full Journal Feed podcast. If you would like to get full access to both the podcast and the blog, then you'll have to become a member. All the details for that are at journalfeed.org. Now, this is the audio version of the past week summaries, which this week were brought to you by our authors Doug Wallace, Aaron Lacey, Seth Walsh, Caitlin Nicholson, Amanda Matthews, and Clay Smith. Okay, let's get straight into the first article, which was titled The 10 Test and Sensory Evaluation of Hand and Finger Injuries in the Emergency Department, out of the Journal of Emergency Medicine. Your hand is one of the most sensitive parts of your body, and it's very important that it stays that way for you to function well. In the emergency department, we have a few ways of measuring exactly how good the sensation is doing in your hands. But a lot of them are they're a little bit cumbersome. The most common that everybody I think is familiar with is the 2-point discrimination test, where you vary how far apart 2 points are. You press down to the point of blanching the skin, and the patient says whether they feel 1 point or 2 points. Normal ranges are anywhere from 2 millimeters to 8 millimeters, and we can use this and compare it to the other digits to see how that patient's doing in terms of their sensation if they've had some kind of injury. However, there's not amazing inter-rater reliability. It probably takes a little bit of training and expertise to do this well, and you have to have something around to do it accurately and more objectively. There are some tools to do this, but not the kind of thing that the emergency doctor is going to really be carrying around. It can be done with a paper clip, but then you're not going to get really accurate distances there. Although I guess that doesn't matter so much since you're really mostly going to be comparing it to the patient's other hand or other digits, especially when the range of normal is anywhere from 2 to 8, which is pretty wide. On the topic of paper clips, I hate to dig on the authors for inaccurate citations, but they say that this 2-point discrimination test dates back all the way to 1835, and they cite an article completely in German, which of course I can't read at all. The authors say that from this original paper, they were using paper clips for this test. However, if you look into it, paper clips probably weren't invented for another at least 60 to 70 years. So it seems unlikely that this test would have been done in 1835 using paper clips. I, of course, could not confirm that this was not the case, given that the article was completely in German and I could not find a translated version of it, or a proper PDF that I could translate, but all the same, it seems a little bit unlikely. Other tests that you can do if you don't want to do 2-point discrimination are the Seamus-Weinstein monofilament test or the Weinstein enhanced sensory test. Both of these are a little bit cumbersome and involve expensive specialized equipment, which again, I don't think that the emergency doctor is going to be carrying that kind of thing around. It also can require calibration for these tools, these monofilaments. So you might be getting really accurate numbers if you're not using recent calibrated materials. Due to the limitations of all these tests, the authors propose another option, the 10 test, which is quick, it's easy to do, it seems to have very good inter-rater reliability, and honestly can be done by anyone at any time without any equipment. All you do is have the patient display their hands to you, and you touch the finger of interest and the same finger on the opposite hand. You have the patient rate the normal sensation on the normal digit as a 10. And then when you touch the other hand, they rate that out of 10. And so you get a kind of percentage of how much sensation they feel on the possibly affected finger. This sounds a little oogity-boogity, but apparently it performs actually quite well. I'm a little bit skeptical of this because I get a lot of patients who say, oh, maybe it feels a little bit less. It's hard to say for sure. This is definitely going to be less objective than some of your other tests, which you could switch up in those cases to make sure that your patient is really being honest about how much sensation they're feeling because you have a real measure of it. In this case, well, of course, I trust my patients. I don't know what I would do with some of the numbers or the variability that you would get there. Like, is 9 out of 10? Like, what am I going to do with that? Should that finger laceration, am I more worried about a nerve injury out of a 9 on 10 or an 8 on 10, even a 7 on 10? I'm not entirely sure. Should that person see plastic surgery, I'd need clearer cutoffs here. Regardless, I don't do a lot of 2-point discrimination just on the day-to-day at a baseline anyways, so it's not that I'm replacing a test that I do frequently. Regardless, though, I like it as an option. I like knowing that it exists, and this is a test that you can communicate to your specialists, and they should know what you're talking about, and is something that they can reproduce as well to monitor the patient over time. It's a useful tool. It's good to keep in mind. In a spoonful, a new sensory test called the 10 test could replace all those other ones which are a little bit more cumbersome for the emergency department. Remember the 10 test. Okay, and then let's skip straight to the 5th article, titled Effectiveness and Safety of Pharmacological Therapies for Migraine in the Emergency Department, a Systematic Review and Bayesian Network Meta-Analysis, out of the Annals of Emergency Medicine. Everybody I've met has their own kind of migraine cocktail for treating migraines in the emergency department, a common complaint. But it'd still be nice to know, what does the literature say about what is the most effective medical treatment? Now, in order to compare everything, it's often necessary to do a huge meta-analysis, a network meta-analysis, to compare all the different options. Because in order to do trials to compare every option, it would be a lot of trials, a lot of money, and frankly, no one's really doing that for migraines. But these authors were able to find 64 different trials for treating migraines and compare them against each other as best as they could to try to see what the most effective pharmacological options were. For adequate pain relief at 2 hours, there was 4 agents that were better than placebo. In the order of effectiveness: chlorpromazine, chlorpromazine, propofol, and then metoclopramide. The best agents to avoid rescue medications at 2 hours was metoclopramide plus an NSAID, IV ibuprofen in this case, which I don't actually have access to, but that sounds pretty cool. And ibuprofen, honestly, usually tends to be the best NSAID we have there, even though people consider it inferior because it's so commonplace. And then second place was chlorpromazine. So I'm seeing some favor for chlorpromazine and metoclopramide use here. When they looked at adverse events, however, there was a significantly higher rate of adverse events if you use propofol or chlorpromazine. Possibly the least effective single agent was ketorolac, if used all by itself. Keep in mind, though, that everything I've said, this is a very low confidence statement for all of these, because there was a lot of heterogeneity between these studies. Network meta-analyses are always kind of messy, so take it all with a grain of salt. I think that I like the balance of metoclopramide plus an NSAID as something that probably works well and wasn't associated with significant side effects. Add some dexamethasone for migraine prevention, and boom, that's my cocktail right there. Though I tend to use ketorolac since it's the only IV NSAID that I have access to. However, even ibuprofen all by itself was not very effective. You had to combine it with metoclopramide. And this gives me some confidence that even ketorolac, because I'm combining it with metoclopramide, is still a good option. That is going to continue to be my migraine cocktail, and it's nice to know that this is evidence-based, even if it's very low confidence evidence. In a spoonful, there are a lot of options for the treatment of migraines. Chlorpromazine and metoclopramide plus an NSAID seem to come out on top for efficacy, though chlorpromazine was associated with more adverse effects. Okay, and that's all 5 articles that we have from this week. Let's do a quick wrap-up of everything we talked about. From the first article, remember the 10 test for evaluating neurosensory loss in the hands. And then from the 5th article, I'm sticking with my migraine cocktail of metoclopramide plus an NSAID, and then I sprinkle on some dexamethasone for further migraine prevention. Now I know that this is pretty much supported, though low confidence, from a network meta-analysis. Again, if you were hearing this right now, then you were not a part of the members feed, and so you missed 3 articles from this past week. What articles did you miss? Well, we had one article that talked about the rates of adverse events from a middle and low income country. The numbers are high. And then, is it worth it to do high flow nasal cannula for all of your sedations? And finally, how well are clinical decision tools actually performing for septic arthritis in children? The Coker's and Caird's rules. It's good to know. Links to all the original articles can be found at journalfeed.org, or just follow the links in your show notes. Our goal here is for you to read less, learn more, and save lives, one spoonful at a time. Thank you.